So welcome. Thank you for joining us. I'm Melissa Barnett, the director of the Francis McClelland Institute. At the Francis McClelland Institute, or FMI, we support innovative research aimed at improving the lives of children, youth, and families, especially those from vulnerable and marginalized communities. We actively partner with community organizations, we share research findings with the community, and we educate the next generation of engaged scholars and community leaders. Our goal is to move beyond the university walls to partner to build communities that promote family resilience so that all individuals have the opportunity to reach their full potential. Our work here at the Institute is inspired and to honor the legacy of Francis McClelland. Francis lived a life that demonstrated, facilitated, and celebrated resilience. She was a generous and tireless advocate for children, youth, and families, especially those who experienced injustice and adversity. We're also really thankful and would like to recognize the support of Pamela J. Turbeville, another University of Arizona and Norton School of Family and Consumer Sciences alum, whose generosity supports this speaker series. And finally, we would encourage you to visit our website, to follow us on social media if you aren't already doing so, and hopefully you will join us at future events. We're really glad you could take the time to join us today for this talk using community-based participatory research to address health disparities in Latinx communities. We're especially thrilled for Dr. Ada Wilkinson-Lee to join us. She's an associate professor in the Department of Mexican American Studies at the University of Arizona. She earned her Ph.D. in Family Studies and Human Development from our program here, and she is affiliated faculty with the Francis McClelland Institute. So we're especially pleased to have her talk today that we were able to reschedule from last spring. Dr. Wilkinson-Lee's research is grounded in working with community coalitions guided by community-based participatory research, or CBPR, and therefore her approach to research is responsive to community needs and encompassing of multiple domains, including reproductive health, access to healthcare services, the built environment, and increasing physical activity opportunities with Latinx communities. Since the CBPR approach guides all of her work, translation is a critical dimension of her research, along with innovative approaches to data gathering and analyses that are responsive to community needs. Dr. Wilkinson-Lee's research has allowed her to combine her interests in Latinx health with a perspective that addresses an individual's developmental processes within larger social and cultural contexts. Without further ado, I'm very pleased to turn this over to Dr. Wilkinson-Lee.
Thank you so much, Melissa. Let me go ahead and pull my presentation up and let's see. Here we go. Can you see my my presentation, Melissa? Okay, just making sure. Thank you all. Thanks so much for inviting me. And like Melissa and I were talking about earlier, where I was saying how I was a little bit sad that I wasn't able to do this presentation last semester pre-COVID, because this is really one of those conversations that's really nice to have when you're in the room with people so that you can dialogue and have it become more of an ongoing conversation rather than me just providing the information to you all. But I'm hopeful that throughout, as things come up, that you'll maybe take note of something that you want to discuss. I am leaving enough time at the end so that we can have a conversation about the work that I'm going to be presenting today. So I just wanted to let you all know that I usually prefer to have a more interactive approach when talking about community-based participatory research. But let's go ahead and get started. I want to begin with a land acknowledgement. So the University of Arizona's Tucson campus is located on the traditional lands of the Tono O'odham and Pascuayaqui people. And as a land grant institution serving the entire state, we also recognize the homelands of all additional 20 other tribal nations on which we work and live. We pay respect to their cultures and histories, as well as to the indigenous people everywhere when we act to foster a diverse and inclusive wildcat community. Being in line with the Land Grant Acknowledgement, I also want to pay tribute to my background, because my background and my positionality, especially coming from when I use mixed methodology, I think it is important for us as researchers to acknowledge our positionality and where we come from, and how we approach our research. And so I have to do that by beginning to and providing you a little bit of background information about myself. I was born in Douglas, Arizona, and for those of you on this webinar that don't know where Douglas, Arizona might be located, it's actually a border community here in Arizona, southeast of us, about a 2-hour drive from Tucson. And the sister city on the other side, on the Mexican side, is called Agua Prieta, and it's in Sonora. And so, and to be even more specific, I tell people I'm from Douglas, but in reality, I'm from Turbeville, or Pueblo Nuevo, which is a small, tiny little community right next to Douglas. It consists of 4 streets and 4 avenues, so it's tiny. If you ever drove by there, you probably would have missed it. But I'm from Turbeville, so I think it's important for me to share that. And the reason I share this is because growing up in Douglas on a border community, I didn't realize the impact that me being from the border actually had on my research trajectory. But looking back, hindsight, I realize now that it had played a huge role. The reason being is that even early on, I recognized that there were differences in the resources that were available on the Douglas side, and then also on the Agua Prieta side, with regards to accessing healthcare. And so what I would notice is that people in my community, family members, if they didn't have health insurance, they could easily access health insurance in Mexico. And if people in Mexico needed to see a specialist and maybe there wasn't one in Agua Prieta, they could easily travel to Tucson to see a specialist. And so, even with regards to like modern Western medicine, there was also this notion of using traditional medicine or more holistic medicine to deal with some of the things that were like day-to-day scrapes or wounds and things like that. Growing up entrenched in this, I thought that that was normal, that everyone did that. My grandmother, my abuela, lived in Mexico, in Agua Prieta. And what I didn't realize is that she was known as like the neighborhood healer. And people would call her Doña Maria as a sign of respect because they all came to Doña Maria for like those herbal remedies. They came to her when someone was about to give birth, because she was like, she had been through a lot of stuff. So she actually knew how to deliver babies just because of where she came from. She grew up in a small little like community in Mexico, and so she had all this knowledge. Again, I thought everyone had someone like my grandma, growing up. And it wasn't until I came to the university, which was a little bit more removed from the border, that I realized that that wasn't the case. And so what this background gave me an appreciation and an understanding, because I saw the challenges in the community, but I also saw the resiliency and how people overcame some of those health access issues by being very innovative and seeking out ways to still provide healthcare for themselves and for their family by maybe turning to those traditional methods. And so that really helped kind of guide me as a researcher and my approach and perspective in how I treat every research project I go into. So I don't attack it or come at it from a cultural deficit perspective, but I come at it from a cultural assets approach of really working with the community as collaborators on the research project, rather than me coming in as an expert and telling them this is what we're supposed to do. So I feel a little odd doing this presentation on my own, because oftentimes what we do is we try to really incorporate our community partners to really have that kind of meaningful conversation and really owning the findings and the information that we put forth. But my community partners did do help a lot with some of these slides, and they know the information I'm going to share, and so I feel a little bit better about that they were vetting the process and also aware of what I was going to share today. So just this is my positionality and giving you that background information as I move forward and talk to you about community-based participatory research. So I want to begin with talking about the Latina health profile. Now, this is not going to be comprehensive. We can spend a whole semester, a whole course that, dedicated to Latina health profiles. But I wanted to give you a little bit of context based on what we focus on with our research project. So the Latinx community does have the highest lifetime risk for diabetes. Along with that, other various cardiovascular disease risk factors such as obesity and hypertension have also become an increasingly pervasive burden of Latinx communities in recent years. And what we also recognize is that chronic disease can have a negative impact on emotional well-being. So adults diagnosed with chronic diseases are significantly more likely than those without to report lower emotional well-being. Now, we know that negative emotions in turn can really reduce your ability to self-manage diabetes or other chronic conditions. So trying to have people engage in modifiable behavioral change, such as healthy diet or adequate physical activity, sometimes can be a challenge. And what I want to do is give you our definition of emotional well-being, because people operationalize it differently depending on project to project. So I want to give a clear definition of how we view it from our research perspective. So emotional well-being is the perception of overall satisfaction with life, making sure that you have quality relationships, positive emotions and resilience, and then also being able to realize your own potential and overall satisfaction that things are going well. So when we think about people that are caring for people with a chronic disease, sometimes primary care providers find themselves increasingly addressing issues such as depression and anxiety that usually adversely impact disease course. So when chronic disease and emotional health problems are not treated concurrently, there's a risk that both conditions will worsen. However, these comorbid conditions have received attention in the scientific community, but the public health interventions have lagged behind the scientific community and have only marginally begun to address emotional health in practice. So the result of that system is that the system is inadequately equipped to address the interconnectivity of these illnesses, which subsequently impacts both the suffering of individuals and the communities. Well, what does the Latinx community in Arizona look like? Our project focuses on it. We don't focus on all the counties, but we do have a partnership with Pima County, Yuma County, Santa Cruz County, and Maricopa. And when addressing health disparities in the Latinx community, we have to take a very comprehensive approach that addresses social determinants of health within Latinx communities. Of course, this is a lot more challenging to focus on structural or institutional factors that are impacting our community's overall health and well-being. And oftentimes when you look at interventions or public health interventions, many times historically they have been focused on individuals. And we are now seeing this push and this drive to make sure that we're looking at it from a family as a unit way of approaching health and public health, and then also looking at the well-being of the entire community. So then you might be asking, well, why focus on community-based participatory research? And I don't know if you all have a course that focuses specifically on this type of approach, or if it's covered, or how many of your faculty use CBPR research. But the reason why I focus on community-based research is that the structural barriers in underserved communities limit individuals' ability and access to effectively participate in their health decisions. So what do I mean by that? I mean, if a person is dealing with daily chronic stressors because they're working 3 jobs, they don't have health insurance benefits from those jobs, they are food insecure and are worrying about how they're going to put 3 meals on the table, and are dealing with not knowing whether or not they're going to be evicted from their apartment or their home because they can't make payments, then when we come in as providers and as public health, providers, and say, oh, you should be we're exercising, 5 to 7 days a week and eating really healthy meals, that gets moved down to the bottom of their to-do list because they're dealing with so many pending issues that are critical right there and then, right? So then how can we move the health of an entire community forward if we're not addressing those structural barriers that really impede them from moving forward with their optimal health? So we do this by increasing community level capacity in health education and intervention. And that's the way that we're going to narrow those most pressing health disparities to achieve the Healthy People 2030 objectives. So therefore, engaging the community in the research process places the needs of that community front and center. So as I stated before, our research projects really do try to engage as fully as possible in this idea and the core principles of what CBPR research looks like. And so I wanted to spend some time talking to you about what does community-based research approach, what does it look like? Because if you were to ask 20 different researchers in CBPR or people who use this framework, you might get different answers on how they define CBPR approach. And there are core principles behind CBPR, but I wanted to provide you with the way that I view it. And I view it as more of being on a continuum where it's a framework and researchers and interventionists kind of pick where they feel comfortable or where they feel that they can incorporate it with regards to maybe some of the limitations, whether those limitations are on the funding side or whether those limitations might be just in personnel or within the research team. So this isn't to say that, oh, if you're in this part of the continuum, it's bad. It's just to give you that framework of what that continuum looks like. And then you as the researcher can decide where you kind of fit in that continuum. So the first one is a top-down approach to an intervention to a community identified issue. So we see this a lot where a research team will go into a community and do a needs assessment and say like, oh, the community is the one that told us what their needs are. And those needs are what's driving our research project, which is great, right? We always want to get community input on what's happening, because if you have this great design and you come into a community, you're like, we're going to solve hunger in this community. And the community's like, we don't care. We're interested in you fixing potholes. It's not going to go over well. So you have to meet the community where they're at. And so, but it's still a top-down approach where you identify the need, but really the focus is on the researcher side of the house, where the researcher's still driving the research questions and hypotheses, driving the research design, the data collection, the analysis, and then the disseminations of findings. As we move in this continuum, we have the incorporating some community input into the intervention. And this could take various forms. So this could be in the form of forming a community advisory board or a community coalition that really helps the researcher, the research team formulate what you're going to do. And this could be at various levels, right? So it could be The Community Action Board helps with recruitment. They're stakeholders in the community, so they help facilitate connections that you might have with your population on how to recruit and retain your population. They may give input into the types of questions or assessments you're doing. They may even give input into the actual intervention itself. But it's still pretty much controlled by the research team. What I call it the optimal approach to CBPR is something that's community driven with community partners as the actual researchers and then owners of that intervention. So this is what we strive for in our research study is we really view our community partners, as equal researchers in this approach. And we work on everything with our community partners. So our research project is out of the Arizona Prevention Research Center, out of the College of Public Health. And we apply every 5 years for funding from the Centers for Disease Control and Prevention. And our partners are actively involved in our proposal, development of the proposal of where we're going to move forward in the next 5-year iteration of our research study. They're in the budget. They're working with us. Everything that you can think of, the research questions, the aims of our study, where we're going, how we're going to recruit, the recruitment materials, the our baseline materials, our interview questions, the intervention itself is very much driven by the community. And when I talk about partners, there's partners from all different organizations, but in that partnership are also our community health workers or promotoras. So they're actively engaged, and our promotoras are really what drives our project. I always say, like, they are our project. They're the ones that are also the data gatherers. So different projects may work with promotoras or community health workers, but they may have a small role in that project. Our promotoras are highly trained, and they're the ones that recruit for us. They're the ones that consent all the participants. They're the ones that do all the baseline and follow-up assessments. They're the ones that carry out the intervention. And they're the ones that also do our data analysis with us, in partnership with us, and they disseminate our findings. So when we go to conferences like APHA, the American Public Health Association conference, it's our promotoras, along with maybe one of us, who presents that information. And it's usually the promotoras who are the stars of those presentations, because they don't really want to hear from the researcher. They want to hear like the nitty gritty. They want to hear about what were the day-to-day experiences? How did you help participants? And oftentimes we present case studies, and the promotoras, do a phenomenal job because they're in it. They're in the trenches. They're the ones that are gathering that data. So I just wanted to give you kind of an overview of this continuum of what it looks like, so that you understand where I'm coming from when I say community-based participatory approach. I don't want to make assumptions that everyone knows what it is. And so I just wanted to give you the way that we view it in our research study. So I already kind of talked a little bit about the importance of promotoras or CHWs, but for some of you, this terminology might be new to you. Some people use different terminology. They may say health advisors, health navigators. Different organizations will use different terminology for promotoras. But the promotoras are really the experts in the field. And what makes them so great is the fact that they are from the community. And because they're from the community, they're invested in the well-being of their own community. So sometimes when we're working in our projects and maybe our recruitment is low, our promotoras will almost kill themselves, making sure that they're getting the participants. And we're like, wait, slow down, it's okay. Like, you don't have to rush to get the numbers, because they're really driven and they're very passionate about the work that they're doing, because they believe in the work that they're doing. because they own the work, because it's their work, right? So they've been, they had a hand in every aspect of what we're doing. And what that allows them to do is to be like this walking, almost book of knowledge of all this information, because they have all those resource information at hand that they can provide to our participants. Now, we work hand in hand with the Arizona Community Health Outreach Worker Association, or for short, it's ASCHW. ASCHW is one of our partners, and they provide all of the voluntary certification of our promotoras. So sometimes critiques of the use of promotoras, and I don't like to say use because it's like almost like, oh, you're using it. No, when you collaborate with promotoras, with your research study, oftentimes they say, well, they're not professionals, or they may be limited in the skills that they can provide. We don't see it that way. These women are, in our project, it's mainly been women promotoras. We haven't had a male promotor, but they're highly skilled, and of course, not only skilled in the chronic disease that they're focused on, but they're also skilled in the resources available in the community, and then skilled in interacting with people, in building rapport instantly with people so that people feel comfortable with them, sharing very sensitive medical information with them. So I wanted to give you a little bit of an overview of our research project. And our research project is LINKS for short, but LINKS stands for Linking Individual Needs to Community and Clinical Services. This is the last 5-year iteration of our project, and we've now moved into the second 5-year iteration of the project, and it's now called Unidos. But let me just give you a little bit of background information on LINKS. This core research project began in 2014 through the Arizona Prevention Research Center, and it was a way in which CHWs could strengthen communication and collaboration between a CHW in the clinic and one in the county setting. So what we were trying to see is how county CHWs could connect patients to county and other social determinants resources. So what we're trying to do with this project is really utilize promotoras as navigators so that there wouldn't be gaps in services for participants using the clinic, and so that the county promotora could really navigate and help facilitate people to those resources that were really focused on some of those social determinants, whether it was seeking out services for financial assistance, for food insecurity, if they were dealing with legal problems. So the promotora was really there to help navigate through all those different systems. And one of the health outcomes we looked at was emotional well-being. There was a lot of other things that we looked at. We also had access to the patients or the participants' medical records that we could link them back up to see how well they were doing. We wanted to see whether or not their blood pressure went down, if their H1C1 became normal, normal range, their BMI and all those things. But for the purpose of this presentation, I'm only going to share the findings of just one of the many things that we looked at, just to keep it within the time frame. Here's a description of our participants. So we had 129 participants. Sorry. The majority of the participants completed at least 5 of the follow-up visits. So the intervention, we had a baseline, and then the promotoras followed up with individuals once a month for up to 6 months. And as you can see, the majority of our participants were female, so about 86%. We only had about 27 males participate in the study. And most identified as Hispanic, with 82% being born in Mexico. And if you look at the table, and hopefully you can see the table and it's not too small on your end, But for this study, we focused on 3 different clinics, El Rio here, which is in Pima County, Mariposa, which is in Santa Cruz County, and Sunset, which is in Yuma County. You'll recall that I mentioned that part of what the intervention and what the services that the promotoras were providing is that they were trying to provide services for social determinants of health needs within our participants. And the majority of the need really came for English services. So people were trying to figure out how to increase their level of English, whether it's speaking it, reading it, comprehending it. And of course, this is across 3 different counties. So the needs were different based on the counties, but these were the top needs: food security at 50%, housing, transportation, employment, and then you see legal services there. And legal services was broad. It covered everything from, dealing with immigration status to dealing with issues regarding to like minor issues of custody decisions, those kind of things. So it was like overarching what those services were. But just from this list alone, you can see how our promotoras really have to be able to know how to navigate so many different systems in the community. They have to be well-read in all of these different areas and be able to provide that connection to our participants based on the specific need of our participant. So they are very well versed in the information that they can provide in their specific county. So what we find is that support that was provided by the promotoras, it broke down into different types of support. And this came out of not only the quantitative findings, but also our qualitative focus groups that we did focus groups with our participants, some of our participants, and then we also did focus groups with our promotoras themselves. The first type of support that came out was emotional support. So the promotoras were able to listen to the challenges of the participants in a very non-judgmental fashion. Of course, this comes when we train our promotoras on the 10 core competencies of what it means to be an effective promotora. And this is also something that we as researchers train our students and ourselves on how to kind of engage with participants in a non-judgmental, neutral fashion. But with promotoras, oftentimes that means that they almost have to have like this instantaneous connection with their participant, because oftentimes it's rooted in something that can be very traumatic or something that's very sensitive to the participant. So there is that need to build that instant trust with the person that you're engaging with. Appraisal support, this is where they are able to assist the participant in a process with regards to a specific problem and what they want to work on and to identify the next steps. So the whole purpose of the promotora is not to become like that helpline where there's a codependency. The purpose of it is for the promotoras to provide resources on how the participant can learn to self-advocate and become users of the healthcare system. So at the beginning, people might just be overwhelmed, right? They've just been diagnosed with a chronic condition. They're overwhelmed. They may not know the system. They may not know how to navigate the system. And so it's the promotora's job to come in and say, okay, let's calm down. Let's figure out a plan. Like, what's the specific thing you want to address? How can we go about this in a very systematic approach so that we can build a plan and we can move forward and get the answers that you need so that you can feel good about the decisions you're making. So you can begin to know how to advocate for yourself, what questions to ask your provider. Informational support, they know the community, so they know what's available to our participants. They know how to access those resources, and then provide that information back to the participants. And again, tangible, it's very concrete assistance to assure that the participant has the accurate information. The nice thing about what the Promotora does is that, of course, any of us could provide participants or individuals with a sheet that says, oh, here, go to El Rio. They have services there. Or here, go to Banner. I'm pretty sure that they can see you and take care of you. But what the Promotoras do is they go a step above that, where they provide them with a resource, tell them like how to register, how to get there. And then they call every month to check in on them. Like, did you seek out that service? What happened? Did it work out well? If not, you know, let's figure out a different approach. Let's find a different resource for you. And for the purpose of our research project, the check-ins were on a monthly basis, but that didn't mean that the participant couldn't call or interact with the promotora on a weekly basis if they needed them. And that's what we found from the focus groups we conducted with the promotoras, is that they became, you know, that person that a lot of participants went to more often than at the start, just to seek almost like the affirmation, like, I did this, is this right? And then as they progressed, they became more comfortable with seeking out those services themselves. But they would call in to just check in, almost like a friend, like, hey, guess what? This is what I did. Are you proud of me? Like, I can do this now on my own. So you saw that progression even as the participants moved through the intervention, that they felt a lot more comfortable seeking out those resources themselves. So what I wanted to focus on is just one of the scales that we use, the social support inventory. And maybe many of you that are on this webinar have used this social support inventory. I know that this slide is pretty busy, but I wanted to give you what the scale looks like. It's a 7-item scale that is a self-report on structural, instrumental, and emotional support. So the first 6 questions are on a scale of 1 to 5, where 1 is none of the time, 5 is all of the time. The last question is a yes/no response. And so what the score comes out to, there's a range in the score from 8 to 34. So the larger the score, the greater perceived social support that person has. So an example of the questions asked is, can you count on someone to provide you with emotional support, talking over problems, or helping you make a difficult decision? And so this is what our findings look like. The gray lines are all of our participants and their trajectory on how they all scored. The other lines, there's actually 3 lines there. You can't see the third one very well, because the third one is the purple line, which is the overall trajectory for the overall population of our participants. But remember what I said is that we had a lot of women in the study and not that many males. So that's why the female and the overall lines are identical. And that's why you can't really see the purple line, but it's there. So what we find is that we did this assessment at baseline at 3 months, and then also at 6 months. The mean increase of 2.5 units from baseline, there was that mean increase from baseline to 6 months follow-up. And it was statistically significant. 57% of the participants had an observed increase of social support index score from baseline to 6-month follow-up. So like any survey, the results could be subject to different effects and biases, and we recognize that. One of the strengths that I did want to bring up, and it's not something that I cover here because it's its own like part of the study, is that we not only asked participants to self-report, but we also documented the CHW's perception of how the patient was doing based on their own observations and their discussion with the participants. So what we found from the CHWs is that they could really gauge where they were, patients were more readily than oftentimes the participants themselves. They knew because they do their case management and they follow up with the participants. And what our promotoras indicated was that sometimes our participants had that almost social desirability bias, right? Where they took the social support index and they said, oh, everything's great, everything's fine, you know, nothing's wrong, I have a ton of support. And then when they had the one-on-one conversation with the promotoras, that's where the challenges came out. And they said, well, you know, I'm not really doing this well, I don't feel as supported. So that's why it was so important for us not only to gather data on self-report and then of course the electronic medical records to show us the actual health outcomes, but then also to gather that information from the promotora's perspective. We also broke this up by quartile just to see what it would look like, to see what the benefits were of the intervention based on how people self-reported on the social support index. And what you see here is that the green line, those are the individuals that scored the lowest. And you can see that that's where we had the greatest gains in how people were self-reporting or perceiving their social support. So at baseline here at the green, they started at 18. So remember the range was 8 to 34. They started at 18. By 3 months, they were up at 24. And then by 6 months, they were at 25. Now we do acknowledge that those individuals that started really high, that had a high perceived social support index, they don't have much room to grow, right? Because as you can see, they started off at 33 out of 34. So we do recognize that this does help us to see the ceiling effect of that they couldn't really move much, but also when you're conducting interventions and public health interventions, especially ones that are dealing with chronic disease, we also recognize that, and it shows in the literature that people tend to go dip down a little bit as programs continue on, because really what we're doing, we're asking people to make difficult changes. And these are lifetime changes, right? So you're asking someone who has diabetes to alter their diet, the way that they do physical activity. And just like all of us, you know, now, and we can see it, you know, with the pandemic, right? People are saying socially distance, stay inside. And then after a while, people are like, no, I don't want to socially distance anymore. I'm going to go and do things. So this is the same approach. And this is why public health is so challenging, because we're asking people to change their behaviors over their lifetime. So that's where the challenge kind of comes in. But we recognize that we need to continue to do so, and then provide people with resources so that they're actively engaged and wanting to do that, not being forced to do it, because that's how they're going to maintain that change over their lifetime, rather than having someone feel like they're being dictated to, told what to do. I wanted to share a little bit of our focus group findings and provide you with some of that information. These focus groups were conducted by 4 of our promotoras. So they're the ones that facilitated them. We did 6 focus groups with the N size of 52, and they were done 2 per site. So 2 in Pima County, 2 in Santa Cruz, and 2 in Yuma County with linked participants. And again, these were done at the end of our 5-year project. The focus group participants were primarily Latinas, ages 33 to 83, and they were asked questions about their health, challenges to being healthy, resources acquired to promote emotional well-being, and then the recommendations for improving links. One thing to note is that, again, so the CHWs conducted the focus groups, and then our community action board, we have a large community action board, but then we also have subgroups within that community advisory board. And one of the community subgroups is the research subgroup. So this research subgroup, actually, all of the participants worked on analyzing the focus group data. So we had a meeting where we all converged, we all met for a day, and people took different nodes and analyzed, and then we moved around so that everyone had access to the different nodes that were emerging, and then we came together as a large group to go over the findings and make sure that everyone was happy with the way that the themes kind of broke out, and also the sub-themes that it had emerged. So we had 4 main themes that emerged: barriers to maintaining health, prevention strategies, the CHW effect or impact, and recommendations. So for the purpose of this talk and for the sake of time, I'm only going to focus on the last 2 themes that emerged. The first one was the CHW effect or impact. So one of the participants, and just to note, the focus groups were available in English or Spanish. People could, have them done in either language. The participants in our focus groups, they all prefer to have it done in Spanish. Even though our promotoras are bilingual, we went with the choice of what the participants wanted. And so I provide you with the English translation, but the focus groups were done in Spanish, transcribed in Spanish, analyzed in Spanish, and then we did the English translation just for the purpose of dissemination and for publication. But even when we publish, we try to publish both the Spanish and the English components of it. So, so here's a quote: "We have a lot of information now that we didn't have before, and we feel we have a lot of trust in you." So this was a big thing that emerged with our participants, is that that trust that they built with the promotora, that they could really talk to the promotora about anything, and that the promotora wouldn't judge them, but would provide them with strategies of how to move forward. One of the sub-themes that also emerged was this whole issue of empowerment. So they gave examples, like before, sometimes people would tell us, give us information, but you actually walked us through it. You provided us with the reasons why we should do the things that we do. And so now we have all this information, and what we're doing with this information is we're taking it and we're sharing it with our family and with our friends, and we're actually making changes at the family level, at the community level, because we feel like we know this now. Now we can actually go out and provide information to our loved ones as well, and to our friends. For recommendations, we asked them, what could we do as a research group to improve the study, the participation of the study? And they actually talked about including a variety of group activities to counter social isolation. Now, keep in mind that these results were pre-COVID. And so our population was already dealing with social isolation because they are older. Many of them have retired. And so they were already feeling socially isolated. So if we are thinking now, post or during COVID, that those individuals may be feeling more socially isolated because they have to be socially distancing. And when we ask, well, what kind of group activities would you like to have? These are some that they mentioned: self-esteem training, dealing with depression, nutritional label reading for classes, culturally relevant cooking demonstrations. And then they were saying it would be nice to do physical activities as a group. And then some of the ladies said, but we would prefer dancing. And then that kind of led into, we need to include more men so that way we have dance partners as well. And then the men can also benefit from these courses. And that was one of the challenges that came up that that weren't mentioned here, but they said it would be nice to do this study or include more men so that it becomes more of a family approach to health, because oftentimes they felt they were challenged by their partners or even their kids or their grandkids, like, oh, I don't want to eat this. Why can't you make the food that you normally make? So getting the buy-in from the rest of the family members would help with moving forward and sustaining that type of healthy eating. And so based on these recommendations, as we move forward with our new study, the Unidos project, we're still doing that clinical community linkage and really trying to help people navigate the system and identify social determinants so that they can continue to improve their health. We are incorporating those recommendations from our community members and always from our community partners. So if something's not working with our project, our community partners will come in and tell us, like, this isn't working. This we don't like how this is going, or we need to modify that. And so for some people, and for a lot of researchers, that can be very uncomfortable, right? Because we want to kind of set our protocol in place. We don't want to deviate from the protocol. And that's one of the things that makes CBPR a little bit challenging, actually, for researchers, is that sometimes you have to have that flexibility to be responsive to the needs of the community. So it almost has to be a real-time response to the community needs. And that's what we saw with COVID. We had the Unidos project ready, our protocol set, ready to go, and we were going to start recruitment, and then COVID hit. And the university paused all interactions with participants. So we were thinking, oh no, how are we going to move forward with our project? And we started having conversations with our community partners, specifically at the health centers, and they were saying, our people are really being impacted by COVID, and people still need a lot of resources, and actually the need of resources has just increased exponentially. So what we did is we decided, hey, we can work with this. So we broke up our project into 2 phases. The first phase is really looking at demographics and COVID, the impact of COVID is having on individuals, and what are those social determinants that those individuals are being impacted by, and how can we in real time affect that, help kind of alleviate those stressors. So our promotoras, we're using the REDCap database system. So what we did is we actually built into our database system the Prepare, which is just one tool, assessment tool that looks at social determinants of health. And what we did on the back end of it is, if the person said, I'm having issues, paying my bills, the promotora could then click on yes, having issues paying for services. And then based on the county that they're in, a bunch of resources will populate so that the promotora in real time can say, okay, you're having issues paying your utility bill. Here, this is who you need to contact. And then they could provide that resource and also help them navigate that system. Because if any of you have tried to use any online systems where people are having to, click and register and stuff, sometimes you can lose people in that navigation of the system, especially older folks that may not be as savvy as with using apps or even just navigating governmental websites on where, which paper to fill out. So our promotoras are there to help guide the participants through that process. And then the nice thing about it is that they then check in with the participants. So it's not just a one-time deal where, like, oh, here, go to Tucson Public project, but really, oh, did you talk to them? What happened? Were they able to help you? If they're not, then here, let's move on to the next resource so that we can make sure that your light bill is getting paid. So it was an aha moment to us, because we wanted to move forward with our project. And then we said, well, this is still dealing with social determinants. It just at a very heightened level. And now we're adding the potential of a debility disease on top of that, or someone that's being affected because their family, they're now the caregiver of someone who has COVID. And so this is where you kind of have to take what you have and modify to make sure that you're being responsive to your community. And so that's what we did, and that's what we're continuing to do with this new phase of the project. let me just check to see where I am in time. I wanted to share some of our partners, the names of our partners and a picture. We usually meet on a quarterly basis, and we have like a all-day meeting where we meet and go over things that we need to discuss, and then our subgroups will then break up into groups and discuss the research side of the house. We also have a translation and dissemination subgroup, and we also have a communication subgroup. And so these are some of the folks that are our partners. It's not everyone. Pima County Health Department, the Yuma County Health District, Maricopa Community Health Center, Maricopa County Department of Public Health, the Arizona Community Health Outreach Worker Association, El Rio Health Center, Sunset Community Health Center, and then of course the Arizona Prevention Research Center Community Action Board, which is consists of all of those folks and our promotoras, which are all housed into some of these different departments. I was going to give you a little snippet of the Pima Reach grant project that I'm also involved with, but for the sake of time, I'm not going to go into that one because I want to leave time for us to have a discussion about what I've covered, or if you have questions about a specific aspect of anything, or if you just want to have a conversation about, using CBPR, the challenges, the benefits, or CHWs. I try to really highlight the work that the CHWs do conduct, because I think it's so imperative for us to move forward, especially in this time when we see that there are so many gaps in the healthcare system. This is one approach to filling in those gaps. So these individuals are hardworking, and really what our project, our research center is really trying to advocate is for the integration of CHWs into the workforce, whether that's in the healthcare system or whether that's even at the county or county organizational system. And really recognizing the benefits that CHWs play in helping to be that bridge between very technical things and our population, because we know it's needed. And if those individuals aren't there, or people don't have that support within their own home or their own support unit, then those people are the ones that fall between the cracks and they don't get those services. So that's my rah-rah take home message is just the importance of CHWs and moving that workforce forward. So I'll stop there, and then I'll put up my contact information. If people have questions that we don't get to during this webinar, you can always email me or you can give me a call, and I'd be happy to talk to you about anything you wish to talk about. So I will stop there.
Okay, thank you so much for this really interesting talk about the impactful work that you're doing. What we're going to do now is bring everyone who's an attendee, we're going to allow you to be able to unmute yourself and turn on your camera if you'd like, so that we can try to have a lively discussion about a lot of these really interesting topics. So bear with us as we're kind of bringing you all in, and go ahead and unmute yourself if you'd like to ask a question.
Hi, my name is Adriana Camarena. I'm in San Francisco, and I really appreciate the presentation. Thank you so much. I'm wondering whether one of the results of your studies, whether the promotoras are ever asked for information to be given in a way that's not necessarily just informational, but in whether visual or creative or other forms that are not just literature.
They are oftentimes, we also work with the promotoras they're really creative in their approach to how they handle providing information to participants. So sometimes our promotoras have to walk people through things. So maybe that's by actually showing them how to navigate something, showing them a little clip, like a video of how to do something. They also like to create their own infographics. And so that kind of can provide some information, very simple and something that's like right there at a I don't want to say low literacy level, but you know, that's jargon free, and that can be like a resource that the person can easily pull out and understand. But our promotoras are really dedicated. They spend a lot of time, many times, especially with topics that are difficult to handle. So one topic of one of the case studies that one of our promotoras presented at APHA was a participant who was dealing with domestic violence. And of course, that's a topic that's not easily like, oh, here, just call this number and they can take care of you. But it's almost like walking the participant, meeting them where they're at and walking them through that. So our promotora actually spent many hours just talking to the person, getting them used to, just having them recognize that it was a domestic violence issue and providing that support to the person, and then providing them a little bit with more information and more information. So it was something that wasn't tackled over like a 1 hour period. It was over a series of conversations with the person, where in the end, the person felt empowered on her end to make the decision to leave that relationship and move forward. And when she was able to do that, then the promotora was there to actively help with that. So our promotoras aren't the type that just kind of stand by. They're the type that will be like, I'll drive you. Or if you feel uncomfortable, I will come with you to the health center and sit there with you as you fill out papers and help you through the process. So they're very hands-on and they're very astute to the needs of the participant. And it's very much tailored to the needs of that person. So if that person says, oh, I would like to do yoga, but I feel uncomfortable, I wish, the promotora is going to go and help and help. Hey, let's do yoga together. So they're very dedicated and they put in a lot of time, and they really do tailor the intervention to the need of that specific person.
Thank you so much. It really does seem like the key is accompaniment.
Yes, sometimes it can be, especially for some of the older folks where some of the technology that we're now dealing with could be very kind of scary for them, right? And even now, like when people say, oh, the clinic's not open, but you can do telemedicine or a telemedicine appointment. And some of our older folks are like, what's that? Like I don't, having someone who can walk them through it and have the patience, because sometimes our own family members don't have the patience. They're like, oh, mom, I already told you 30 times how to do this. Like, why are you asking? Right? And our promotoras actually have the patience to not do that, to not embarrass the person, to actually walk them through it until they're comfortable.
Can I jump in?
Sure.
Hi, Ada.
Hi.
So good to see you. Great presentation. I love your positionality statement at the start, and I think I need to consider using that as part of my presenting my own work. So thank you for that. I have I guess logistical question. We were considering using community partners for the first time in a grant that we recently submitted, but one of the biggest challenges for us in not doing this work or only starting to do this work is, how do you compensate your community partners, in terms of the budget? Is there, do they get a salary? We read a bit that you shouldn't compensate them, that there's issues around compensation. So I was just wondering what you do and what your recommendations are.
So what we do is our community partners are put into our budget. So when we talk about, like when we work, let me give you an example. So as CHW, which is the promotora workforce, we put them into the budget as saying like they're going to provide technical assistance to us. They're the ones that are going to train the promotoras. And so then they submit their own budget of their needs of what they're going to do because they are working. I mean, they're working on this product with us. Same thing with the health departments. They're usually the ones, they're on the clinical side of the house, right, with regards to the CHW. So we're going to compensate the CHW because we do believe in compensating rather than a lot of the CHW models that are in the literature is that they're volunteer based. But we feel that because they're a part of our community, they should be compensated for the work that they're doing. So we always compensate our promotoras and also our community partners. Now we don't compensate all of our community partners because what's different about our community action board is that this community action board is a longstanding board that started with Project Export through the College of Public Health, which was bringing in a grant to create a pathway for our young Latino and Native American scholars to go into looking at diabetes and smoking. But they're so committed. These are all people that are like public health champions. So even if they may not be getting, they're not in the budget this go round, they still continue to work with us, knowing that they're moving forward the agenda of the platform that they're interested in. So some of them are in our budget and some of them are not.
Yeah, no, thank you for differentiating, because I can definitely see how a promotora could be in the budget, but I guess I was thinking more about those like that advisory board or and so that's really interesting. I might just have to reach out to get more specifics.
Yeah, please do.
I have a follow-up question. I was just wondering if in your work you've ever seen any effects or interactions with children as language brokers. And usually before promotoras, or if you're not in the use of promotoras, and you know, children tend to be the language brokers in the healthcare.
Yeah, I mean, we have seen it in the community, right? And that's the whole purpose of the utilization of promotoras, because now instead of having you know, taking your teenage son with you to an OBGYN appointment, if you need that person to accompany you, that could be the promotora, right? So that it's someone who is removed, not a part of your family, because we know that changes the dynamics when you have to have a child broker. It changes the parent-child dynamics, and we don't want to do that. We want to make sure that doesn't happen within families. And so the promotora is a really great way of someone who can help navigate that without putting a family member, you know, in the middle of maybe very improperly translating something because they're young, right? They're not trained in medical terminology and how to provide back the diagnosis correctly to their parent. Whereas a promotora has more experience. They can provide that translation, that accurate translation to the participant rather than and we also talk about, you know, that whole issue of empowerment, of advocating for yourself, becoming health advocates and having that health literacy. That's part of what the promotoras do, right? So they talk to their participants and say, like, you should be asking these questions of your provider. You should be questioning this. You should be asking for a second opinion. Because of course, sometimes it's cultural, right? Where we're like, oh, well, they're the expert, they're the provider, they know best. And so getting comfortable in questioning or asking follow-up questions is huge in our community. And so the promotoras can also model that behavior for the participants, because they can go in with them and say, start asking those questions. And then the participant says, oh, it's not that scary. I can ask those questions, or I can do it in a way that's still respectful, right? Sometimes they think, if I ask questions, then the provider thinks I'm questioning them and it's a sign of disrespect. When in reality no, it's your health. You have the right to ask all these follow-up questions.
Thank you, Ada.
Thanks.
Hi, Ada. Nice to see you.
Nice to see you too, Katie.
I just have a question about, first of all, it was a wonderful presentation, and I really appreciated the ways that the approach to looking at at community members, but also community health workers. So understanding the process for them and for community members. So that was really, really interesting. I'm curious about your thoughts on training. So you mentioned classes, or I'm thinking about our department specifically, FSHD and the Norton School. We don't offer specifically a research class on participatory research. Do you have suggestions on students and even faculty who are interested in pursuing this work? And do you teach a class on this?
I mean, I incorporate community-based approach in my research methods course. And if you ask any of my students, they'll be like, oh, here she goes again, because I'm always talking about it. But I think, and I've also done some guest presentations for when Andrea Romero was part of your faculty and teaching the courses there. I would do a presentation on CBPR. For students. I mean, I think that there are some standalone I think public health does a CBPR and evaluation course with one of my colleagues, Maya Ingram, and usually Jill DeSapien. They both co-teach that course. But there are resources. So if students are interested and they want to take a course that's a standalone, I would recommend that one. And like I said, I usually incorporate it into my research methods course that I teach out of Mexican American Studies.
That's great. Thank you so much. And that's a great idea about research methods, being able to really incorporating that into existing research methods class. Thank you.
Sure.
What was the class in public health?
I believe it's called a CBPR and evaluation, or community-based approaches to evaluation, something like that. Melissa, I will get the specific course number for you because they're teaching it right now. So I can just ask Maya.
Perfect. And I'm going to steal another question if I can. I'm just wondering, you may have covered it, and maybe I was focusing on something else, another part of your presentation, but I'm curious if the promotoras are being tapped into right now in terms of COVID. If you've heard, you know, what do you do in terms of, I know, for example, in Mexico, people are afraid to go into hospitals. So I don't know what, how that translates here in the US, and I'm just curious if they, what is their role right now, if you've heard from them.
Right now, our promotoras are working remote. So we don't require them to engage, with the community because we want to make sure that they're maintaining their health as well. So what they're trying to do is, well, I take that back. Some of them do work for county health departments. And so the county health department does require them to come in to work from the office where they're wearing masks and things like that. But from our perspective, from our research project, we're not forcing anyone to go out and actively engage like person to person. One of our promotoras in Yuma County is like a real go-getter, and she's like, I'm ready. I want to do the groups, and we're being very cognizant. We don't want to call them like support groups because of the connotation around that concept of support groups. But what we want to do is group activities to foster a community between group members. And she's like, I'm ready to do it. I want to do it. I can do it socially distancing at the park with like 5 people, and we can be spread out. So they're wanting to have those interactions. And our promotoras are so used to that face-to-face contact. But right now what they're doing is they're focusing on phone calls with participants and Zoom calls with participants. That's also one of the questions that we're asking is access to technology, because we don't want to make assumptions that people have access to technology, that they're comfortable with it. we also don't want to run up people's minutes if people are having to do everything on their phone. So we are trying to be very sensitive to that. And if that's something that becomes a barrier, then we need to find a way to overcome that barrier. Okay.
So it's 4:45 now, so I understand many of you may need to leave, but I'm assuming that Dr. Wilkinson-Lee would be happy to stick around for a couple of minutes if there are some of you who have some other questions or more discussion. But thank you for coming, and thank you so much for this talk. I think it was a good reminder of all of the kind of work that we should all be doing as we really look to do research that's impactful and it's in partnership. So thank you very much.
Thank you, everyone.
Hi. I just had a quick question. I actually took a class, it was called Action Research, and it was a pretty long time ago. But I was just curious, have you, because you have the community members like help you write the questions, when it comes to publishing, do you have any trouble publishing in this area? Like, because that was one of the things that we talked about in that class, is that because you don't always use like the standard questions, because the community members are actually like helping you come up with the questions. I was just curious if you run into that at all, or if things are changing.
So we do run into that, and my colleague, my co-PI on it is a social psychologist. So I know that when our community partners are saying like, oh, well, I don't like this scale, let's change it, I could see him almost like freaking out a little bit. but I think he's learned that now there is more, as long as we can justify the reason behind making changes, or maybe removing a couple of the items, but trying to keep some of the items, but maybe shortening the version that we're using. So we do try to keep with some of the scales, but many times our community members are like, no, that's too long. Like 10 questions is too long. We need to shorten that. And so we base it based on participant burden, because we are asking a lot of different questions, a battery of assessments. We also want to be mindful to the amount of time the participant is spending. The same thing happens when we talk about changing the Spanish translation of something that has already been vetted in the community. They say like, oh, but so-and-so already, validated that. I'm like, yeah, but did they validate it with people in Arizona on the border with our like specific demographic? There's a great person here at the U of A. Her name is Sonia Colina. I don't know if you're from Arizona, if you know her work, but she does. She has articles on the whole issue of translation and how we have to move beyond, just back translation. And her articles talk about it's more important to interpret what you're trying to say and write it that way than a literal translation and then doing the typical protocol of the back translation. So using her work, then we can kind of justify, well, we made these changes, but it's to be reflective of our geographical location, because of course we can't make the assumption that just because we're all Mexican American or Mexican origin that we're all going to have the same vernacular, speak the same language. And so that we try to make the case as to why those changes were made. And I believe that a lot of journals are more accepting of that now than they used to be.
What was her name?
Sonia Colina. So the last name is Colina.
This was such an excellent example of like a successful, I've heard about action research. I read some, but this, I just wanted to say that this was such a joy to like see how it really can like impact a community. So
Oh, thank you. Thanks for sharing that.